Our next presenter, Jacqueline Scott, is a senior attorney with the Center for Sustainable Health Outreach. This is part of the Harrison Institute for Public Law at the Georgetown University Law Center. It is also, and she'll correct me if I'm wrong, I'm sure, it also involves the University of Southern Mississippi. It's a joint project. But as we talk now about what we're doing, that is interoperability, multi-agency responsiveness, multi-agency decision-making, not just, again, the technologies that enable real-time communications, shaping the direction that response is going in, but in this instance, talking about those population sectors that are the most difficult to access. And I think, if you recall, I mentioned that I had been working on how do we best alert and warn the deaf and hard of hearing here in Maine earlier. And you get into that type of work activity and you suddenly realize how challenging it can be. So this Scott is going to talk specifically about this whole issue, bringing healthcare, bioterrorism response as it impacts on vulnerable populations. And without any further ado, Jacqueline Scott, we welcome you this morning.
Thank you very much, and you have to bear with me. I'm used to being right there with you, so this is my first time using this kind of technology. So if you can't hear me or something's not correct, just shout out and I'll try to redirect myself. And I think my slides are there, is that right?
Yeah, that's correct.
Yes.
Okay, so I'll just say next here and there, and we can move through it. We can move to the first slide now. And what I'm going to hope to do today is to really put a framework around what's happening currently in the public health system and how we could effectively integrate vulnerable populations into emergency response teams. This quote was back in 2002, and it really focuses on smallpox and other attacks here on the United States populations and the importance of us being ready, and how at that point in time we really were not ready despite how much effort and energy folks were putting into making plans and ramping up. We've made some progress now, and as you've heard, many states and many cities have done wonderful things. And so what we are hoping to do now is to make the point that as we focus on the bricks and mortar, as we focus on making the plans to get to communities and cities and states across the country, that we need to make sure that we keep vulnerable populations in mind. So to make the point more clear, it's just to say that, social inequity affects all aspects of public health currently, and bioterrorism preparedness is no exception. Whether or not we leave some people behind as we plan for how to respond to a bioterrorist attack really depends on our willingness to closely examine the ways in which a one-size-fits-all approach to planning may not sufficiently protect groups of people who tend to fall through the cracks of our public health system. Next slide. For the purposes of this presentation, vulnerable populations are those groups who, because they are already experiencing greater difficulties in accessing health under the current and normal system and in normal circumstances, they will undoubtedly face disproportionate vulnerability to illness and death in the event of a bioterrorist attack. These are people that we are looking at, the elderly, children, the disabled, the uninsured, the underinsured, those who don't regularly have access to doctors. In addition, we know that if a person, no matter what their status, as we currently heard about the healthcare workers attempting to access the system, no matter what their status, if they are infected as a result of a bioterror attack and it goes undiagnosed, there's a great likelihood that they will infect others. It's just result and consequence. So when we're looking at people who are unfortunately many times unemployed or day laborers, and come in and out of communities, and then go into places where they are, for all intents and purposes, either very isolated or disproportionately kind of disenfranchised from greater systems, then we can really tie the correlation to this population moving in and out of their natural arena and back into the everyday lives that touch us all on buses and cabs and subways. So what affects this population affects all of us. The definition of vulnerable here relies on the premise that current barriers between this population and the nation's health system will affect the ability to obtain necessary information and care during a bioterrorist attack. Indications of vulnerability include geographic and cultural barriers, poverty, lack of trust into the system, ethnic minority status, and speaking English as a second language or not at all. Next slide. So what do we already know? The data from the Institutes of Medicine and others tell us that ethnic minorities consistently receive less health care and less quality health care when they do access the system. Controlling for other contributing risk factors, blacks and Hispanics are less likely to regularly see a physician, less likely to obtain preventative care, and less likely to enjoy equal care once they are in the healthcare system. In addition to these barriers to health care, many ethnic minorities do not speak English as a first language and therefore face daunting communication barriers to accessing care. Unless the public health system takes steps to close these gaps, these same barriers will impact the emergency preparedness system and plans that are currently in place. During a public health crisis, these barriers have potential to significantly impact the level of human suffering that people will experience. In particular, the health system's resources can be very stretched, as we've seen from the experience of September 11th. And they're stretched enormously thin in an emergency of that proportion. And normally vulnerable populations and groups are at risk of being left out. For example, dense urban areas with few doctors will find themselves in desperate need of more qualified health professionals to come in to help them if an infectious disease outbreak occurs. Not only will certain diseases spread more and spread more rapidly in dense populations, but also existing health resources may be insufficient to handle the demand. Additionally, cultural and language barriers make communication of vital health information difficult, and sometimes, if not impossible even, to overcome. So how do we do this? Failed communication of bioterrorism management instructions, such as adherence to quarantine or medication schedules and protocols, could mean the difference between life and death. An example is that, not even in a bioterrorist emergency, but in preparation for any emergency, we are looking at coastal areas that are hit hard by hurricanes. We're looking at Tornado Alley. We just spoke about, Indianapolis and Indiana and the difficulty with tornadoes. Well, in a very coastal region of North Carolina, in a small community a couple of years ago, about 2 years ago now, there was a huge hurricane warning. There's a small population that's now really growing of non-English speakers that have settled into a couple of particular counties in the coastal region. And the experience that folks tell us there has just been very frightening, in that as the communication alerts go out and the TV and the radios are sending out messages, these populations of non-English speakers often are left out of the message until very, very late in the game. And since many are day laborers and go out into various areas outside of their home counties and home areas, they found that during this one emergency, when they came back home to go to their grocery stores for daily stops, the shelves were empty. There was a sheer panic as to what really was taking place. There was no water. The basic necessities were not there. And it wasn't until they found that this community had to come back together to themselves to try to figure out who could understand what was happening, and to reach out to their local dioceses and other parishes there in this community to explain to them what was happening, and to then call for extra supplies for these families, they really would not have been covered. And so this is an example of everyday life, not even a bioterrorist attack or biosecurity emergency. The public health system must specifically account for the special needs of vulnerable populations and communities. And how bioterrorism emergencies will really amplify these needs becomes clear when we use natural emergencies as an example. Next slide. So what does this mean? What do we need to do? What are some of the solutions? Well, I think that we really need, and we're starting to see this across the country, dynamic, unique partnerships among public and private institutions, community organizations, faith-based organizations, and the business community coming together to help ensure that the country's most vulnerable populations are protected in the event of any emergency. Within these partnerships, though, we really need to develop a response to specifically incorporate what we characterize here at the university as a community-based community health worker into these state bioterrorism management teams. These and all of the plans that are being created. We need to incorporate this level of worker at the community level into these systems to offset the disproportionate risk of bioterrorism events posing absolute devastation in some ways and isolation on vulnerable communities. Next slide. Why do I suggest community health workers? And I will refer to them probably throughout this as CHWs for short. Why are they a specific community response to this need? The concept of community health workers is not new. Community health workers have played a vital role in the healthcare delivery system in this country for many, many years, and are very active overseas in the international arena. The term is used here in this country nationally to describe and to unify outreach educators, health advisors, and health promoters. They are often really the vital tipping point people in their communities, the trusted peers and members of communities who daily promote healthy living by educating about disease and injury prevention, intervention, treatment, and whose assistance within the community to its members really help them better understand and access health and human service systems. Next slide. CHWs are also critical in minority and immigrant and rural communities, where services provided by physicians, nurses, and clinical facilities may be limited, or where access to and understanding of those systems may also be limited. They have a greater likelihood of facilitating communication directly with patients and members of their communities, and are more sensitive often to the cultural issues that specific communities are facing. In many communities, CHWs are the gateway to care and consistent links to services. As sectors of the medical community and public health community continue to mobilize and come together around building the awareness around preparedness for emergencies, low-income families and vulnerable populations living in rural and urban areas have to be fully integrated into any new emergency response system. Persons living in inner cities and very rural regions of the country are often, as I said, economically and socially disenfranchised. And as a result, they are often difficult to locate and to serve on a daily basis. And therefore, they often receive very little quality health care. However, CHWs are in these communities already, making links and reaching these groups in a myriad of ways, attempting to close existing gaps. However, I do recognize that this group of workers, this group of grassroots workers, don't necessarily have the high-level medical-related expertise that some may say they need. But we're not talking about diagnosis or treatment. We're not talking about specialties. We're talking about their knowledge of communities, their ability to effectively communicate with members within these communities, and their innate advocacy skills that make them really a valuable resource for community-based leadership in bioterrorism preparedness, and really important members of existing multidisciplinary teams. So how might this work? What is the vision? How do we think that this will link? I'd like to take a moment to try to put all of this in perspective and look at specific examples. Here at the Harrison Institute, we've been taking a look at the plans that the states have been putting together around preparedness. And we've conducted a mini assessment on how these plans actually anticipate providing and reaching the vulnerable populations and caring for these folks in their communities. So for discussion purposes at this point, I'd like to use Michigan as a case study. As a backdrop, most of you know, the Federal Department of Health and Human Services is the umbrella organization for numerous agencies and offices. But relevant to my discussion in this example, I'm going to just focus on the Centers for Disease Control, the CDC, since it's the nation's expert, in disease control and prevention. In order to receive federal funding for bioterrorism preparedness, states had to complete plans which were to look at how they would cover their state in the time of an emergency. Each agency had specific requirements, and so CDC had a number of requirements that it set forth. Next slide. The CDC set out 14 critical capacities organized within 6 or 7 topic areas that had to be met in order for state plans to receive continued funding. The topic areas were bioterrorism planning and readiness assessment, surveillance and epidemiology capacity, laboratory capacity, next slide, information technology, health alert network communications, risk communications and health information dissemination, and education and training. Taking the critical capacities alone listed here highlight the need for a robust networking of partnerships between various levels of government and health personnel at the state and local levels. Note, though, that these capacities are really just the minimum requirements for the bioterrorism planning. I am not going to go into depth about all of the requirements in the interest of time. But providing this as a backdrop, let's take a quick look at a couple of the pieces of Michigan's plan. Next slide. Michigan's bioterrorism plan was created by the Michigan Department of Community Health, MDCH. This was to be their guide, Michigan's guide for bioterrorism response. MDCH was given the responsibility to develop a bioterrorism response plan by the Michigan Emergency Management Planning Agency. The plan background acknowledged the central importance of building a strong public health network for effective bioterrorism response. This in itself is precisely the promise of CHW, community health worker, involvement. Strengthening public health networks at a local level. Similarly, several of the responsibilities that the agency required from MDCH to have in its plan resonate with the skills of CHWs and their capacities. Next slide. The agency required a couple of things that I'd like to highlight. They required coordinating and investigating controls of communicable diseases, issuing health advisories and protective action guidelines to the public, coordinating a mental health needs assessment and crisis counseling, and having liaisons to serve with between federal emergency health and medical programs and services and those at the state and local and community levels. Each of these at a fundamental level within the Michigan plan and within the state agency in Michigan, all of those things at a fundamental level are really closely aligned with what CHWs have to offer. So there was a good match in accomplishing some real grassroots outreach to cover those that are most vulnerable. Next slide. But let's look at their communication and notifications provisions as an example, a specific example of a possible match. There were two main aspects of their communication and notification plan, and they were divided between categories of planning and, as you can imagine, response. CHWs can play an important role in both aspects. Within communication and notification and planning, CHWs would be well suited to participate in many of their planning requirements, disseminating bioterrorism-related materials to their communities, developing and disseminating and participating in education and training programs for health professionals, identifying a special population wherever it may be, whatever their needs are, and coming up with ways to effectively communicate with that population, exploring development of effective communication venues themselves, not just dependent solely. For example, we're talking about in our daily lives as we sit in our offices and we get our email alerts to certain things, or we get our phone calls on our cell phones and our pagers and things like that. Well, many of these communities are, if they're very rural communities, they are not wired to receive these kinds of outlets. We have various organizations and foundations, like the Gates Foundation, for example, that have really taken on very rural communities to try to get them wired to receive this information. But then you turn to even a city like here in Washington, D.C. Many of the public school libraries, unfortunately, are very underprepared in terms of just the use of technology and the use of computers for district residents themselves. So we don't have pockets and places set up to use that kind of technology. But when you look at someone utilizing the resources of someone who knows the community, they could come up with or assist these emergency management teams in their planning on how best to communicate with them. The plan for MDCH to develop the plans also were for MDCH to develop and distribute the materials that describe infectious agents and infectious diseases and symptoms, and to provide recommendations for how to deal with those diseases. How do you prevent morbidity and mortality? CHWs could help in the distribution of that information. And that's only to the extent that we are informing and educating, not giving medical advice. They could also distribute materials to community members and have discussions around and with community members about how to minimize the risk or exposure to certain elements. The plan also calls for the development of what they term an emergency notification network, the effective network for communicating the information to states, counties, localities, and communities. To be effective, community health workers really should be a part of this network. At the time that we reviewed this plan, though, the only folks that were included in this network, the original local partners, were, as you can imagine, the local public health department, local emergency management, law enforcement, hospitals, and clinical laboratories. They did not include the community-based workers. Additionally, there was no requirement for all of the partners to be notified in all emergencies. There were various protocols for notification under the circumstances and depending upon what the emergency was. So, we really look at numerous ways that we really can communicate with and more effectively with local grassroots communities through the use of this worker. Communication and notification requirements of the plan also include developing education and training programs for healthcare professionals and clinical laboratory personnel. CHWs are invaluable in this instance in that they can assist and collaborate in developing culturally appropriate and culturally sensitive modules for programs for other professionals to be able to implement, to also help professionals and emergency responders respond more effectively and interact with these communities in a culturally diverse and culturally appropriate manner. Finally, identifying special populations and specifying means of communications within them is another aspect of the plan's requirements. The Michigan plan specifically identifies that their potential special needs populations are non-English speaking residents, military personnel, students, intertribal councils, the elderly, homeless populations and homeless shelters, non-readers and individuals with low reading levels, and assisted living centers, along with a group of migrant workers that they have there in their state. And these are precisely the realms at which we say that this level of community outreach worker could be helpful. They could identify special populations and work locally with teams of providers to strategize and implement how to be effective and how to communicate emergency policies and procedures to these special needs groups. Well, what does all this look like? Next slide. What we've come up with is a couple of draft diagrams. We've taken the CDC interim recommended notification procedures in the event of bioterrorism attacks and incorporated communications with CHWs. And we presume that there are a number of different levels that it could happen. If a local health officer, for example, is informed somehow of a bioterrorism emergency, or the local health officer suspects that they have a bioterrorism outbreak or some sort of gas release or something, and there needs to be some confirmation on the ground. As they communicate with the emergency response teams, there's a linkage there with the community health worker or a cadre of outreach workers within that territory, within that region, within that census tract, wherever it occurs, to allow some on-the-ground management and notification of residents. And also validation and feedback to what they are questioning in terms of getting the factual basis back to those with the medical knowledge to make the right call, to know who to notify. But at least the communication on the grassroots level is there. On the other side, there are pre-established notification lists that exist in these plans, and we think that there must be a level of trained grassroots worker who is a part of that notification list, so that we can get information into communities that that does not cause panic, that does not sheerly create people's hysteria, but again educates and is able to be a first response on a level of trust that exists there in the community. Next slide. How do we presume that some of this can take place and some of this happen? Well, we know, and we've talked a little bit about this morning, about the importance of training and riding the balance of overtraining, but having some core training done. We've looked at training curricula out there. The CDC has training curricula, and other national and federal organizations and states have developed training curricula. And we think that if you take this core of people and integrate them into those teams that are already receiving this training, you broaden the level of expertise and you broaden your ability to respond at a community level to these incidents. Now, let's look at the community health worker's specific role in the public health department. We've talked about disseminating information. Let's look at the surveillance opportunities. I often use West Nile virus and the instances in Baltimore that took place early on. There was an elderly gentleman a couple of years ago who died of West Nile virus. He went for a number of days not being seen or heard from in his community when he first became ill. Had we had a grassroots or community response, someone in the community that sort of knew him and knew that, well, I hadn't seen, and I don't know the gentleman's name at this point, and that's not relevant, but Miss Brown, who is the neighborhood communicator, could have checked on him. Or perhaps we have community linkages where we are getting the word out to these communities that say, if you have standing water. And all these things are now taking place in the communities in Baltimore and other regions across the country, but it has taken time to ramp up just in a natural response, not even an emergency bioterroristic attack, but in natural responses. So we need to build a greater link to the communities. They also can serve in existing volunteer corps. And we're going to, I think on the agenda later on today, talk a little bit about volunteer corps. So we're not talking about creating additional systems. We're talking about integrating core personnel into existing systems. The same with health providers, the role of CHWs with health providers. Healthcare providers need translators. They need credibility in some of these communities because, very honestly, they don't have trust. And also in very rural communities, they don't have the linkages and the contacts. We don't have as many critical care hospitals as we used to. There's 60 miles between one hospital where one community is and the nearest hospital in some very rural regions of, for example, Mississippi, Alabama, Louisiana, within the Delta. We also can utilize this worker to collect vital information and to disseminate information. And what's their role with the community? Let's talk about if we do need to immunize people. How do we take the fear out of and allow the trust to come in? How do we talk about preparation for things like hurricanes and tornadoes or earthquakes on the West Coast? Things like that. Very basic responses where we can get into the community and get the trusted information there. Well, in the interest of time, I want to wrap up. In case there are questions, there are many more items that I could highlight in the Michigan plan, or many more examples I could give to you from this perspective in terms of creating a link with vulnerable populations. But as we move to the very end, the next steps and the benefits of CHWs, I just would ask you to just take a quick look at the next couple of slides that are there with you to give you some ideas about these benefits that they could offer to you. And just understand that it is important to have and utilize this grassroots worker in the responses that we create as we move forward. The very last slide is next steps into action. I think, again, I'll reiterate that we just need to integrate these vulnerable populations and their special needs into the plans, provide a framework for them in the public health departments, for the public health departments to really develop rapid responses to vulnerable communities, recruit and train a cadre of workers that really already exist out there in these communities and are working daily for health departments and hospitals and health clinics, and also develop culturally sensitive and culturally appropriate training materials for responders to help them feel more comfortable in accessing and communicating within these communities, to help them feel better prepared to do their jobs. So I'll stop there, and I thank you very much for this opportunity and am available for questions.
Well, thank you, Ms. Scott. I think everyone can now better understand why she served in an advisory capacity to the Governor of Maryland. She certainly has done a very good job here in bringing us this very important dimension of the interoperability puzzle. In other words, if we have a map on the wall and you cannot penetrate in to designated areas on the map, designated zones, population centers, because you lack the human resources that are skilled and knowledgeable of that population, then you don't achieve interoperability. When we talk interoperability, we talk, the full level of response. And my first question to you, Ms. Scott, is with the community healthcare worker, as you have described it here, there is no central organization or association or registry of those healthcare workers now. Would that facilitate the overall incorporation of the CHWs into a more responsive national organization capability?
Actually, yes, it would. And what's happening now is that we are working nationally throughout the states to help community health workers organize themselves, define who they are and what they're doing. And there are a number of states that have received funding, private organizations that have taken an interest in making sure that we can locate who these workers are, who is employing these workers, what kinds of training these workers have. Many of them are grant funded or funded to really work in specific health indices. So, for example, a health department may have them spread between their, prenatal care, their outreach programs related to HIV and AIDS or hypertension studies, things like that. So we do need to bring them together, but they exist in every state and are working many times linking now with faith-based organizations that are now branching out to do a health outreach in the greater sense of holistic health and treatment.
But you're right. Later on today, we will talk about Citizen Corps. And we do have the CERT out there, the Community Emergency Response Team. We have the DMAT out there. We have all of these different levels under the NMDS, for example, and I find it not particularly comforting that we haven't been able to formally address this issue of bringing this very important group of healthcare workers into the system. Are you optimistic that things are going in the right direction now?
Well, I'm optimistic. I just think there are a couple of things that have gone on. We have talked with various levels of people in the federal government, in Homeland Security, and in HHS, and we've talked at the very local level to states and counties about this issue, and all recognize that it really is important. I think the issue goes back to, I think, what the very first presenter talked about, some of the burdens that people are having in trying to balance the resources and the time and the critical nature that states, the decisions that states are having to make between where do I put the energy and funding. If I need more fire trucks and I need to train my emergency personnel, I've got to do that first. I recognize these other things are gaps. And that's where we come in. We try to offer them both technical assistance, but also the ability to kind of see where they already have the framework. And then they already have this cadre of workers there, and that it's not so hard and overwhelming to make the
Ms. Scott, stand by if you can hear us. We cannot hear you. You have just lost your feed into UMaine only within the last 45 seconds or so.
a lot of different areas.
So, George has a question, Ms. Scott.
Hi. To what extent can some of these activities be performed by volunteers? Because, you know, there's a lot being said about the resources being stretched thin. I mean, some of the maybe communication. I mean, is that something that we should do more with? Like I see crossing guards. Lots of schools have crossing guards, and I think those are volunteers. It seems to me there'd be a lot of people who want to get involved, even in terms of just, you know, being a neighborhood kind of community communication service.
Well, I agree. And actually, a lot of this work is being done volunteer in most of the rural states. There are volunteer programs out there, even dealing with diabetes prevention and breast and cervical cancer, all kinds of health indices. These groups of people go through volunteer training and are out there in the community because, very honestly, the money is not there to provide for them full-time job opportunities. What we are suggesting is that there is room for both. Where the funding exists, we think that there is a prime opportunity to develop a significant workforce that can link here to help close other barriers in healthcare while helping in this arena. But on the other end, to the extent where there are volunteers and where we have core curricula and standards of practice for these volunteers to be able to do their jobs, then I think we should utilize them. We also created a mini model of sort of a reserve corps, that you have a core group of people who are trained for times of emergencies like this. And so when they're while they may be doing their daily CHW outreach activities, when their emergency duties kick in, then perhaps we have an allocation of stipend or something to support their efforts around that time, much like we do in a Army Reserve Corps or other times, where we pay them for that level or that intense training or that time that they have to be called to serve in this capacity.
Okay, thank you.
Well, thank you, Ms. Scott. I just want to remind everyone that if you'd like more information about the center, and please correct me if I'm wrong, but the website is www.csho.org. And
Yes, and as a matter of fact, you can also link to us. You were right in the beginning. We were originally established as a joint partnership between Georgetown and the University of Southern Mississippi, because we were focusing on helping bring capacity to the rural regions and particularly the Delta regions of the country. So you also can, if you get on the Georgetown University Law Center website, you can also link to the Harrison Institute and find us there, because the Harrison Institute is the umbrella for the health program here that I teach out of. So there's a link also there to us.
well, again, thank you very much, Ms. Scott, for joining us this morning.
Thank
We appreciate
you.
your time and input.
It is my pleasure, and I look forward to the afternoon's presentations.
We're now going to take a break for lunch, everyone. We'll convene back here at 1 o'clock, and we'll get right into the CDC Public Health